Welcome to our webinar titled Transplant for Older Patients with MDS. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of the patients, families, and caregivers who have supported the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window. And when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speakers cannot answer any specific questions related to your personal health care. Today, we are honored to have 2 specialists. Our first specialist is Nandita Khera, who is an associate professor of medicine at the Mayo Clinic College of Medicine and Science and a consultant in the Division of Hematology Oncology at Mayo Clinic. She treats patients with blood cancers, especially those needing blood and bone marrow transplant for their disease. Her research focuses on improving the delivery of care to patients with cancer to help them be better prepared for the psychosocial and financial consequences of treatment. She has also published several papers in the area of outcomes, late effects, and quality of care after transplant. We're also honored to have Dr. Linda Burns, who is a consultant and senior scientific director at the Center for the International Blood and Bone Marrow Transplant Research. From 1992 to 2014, Dr. Burns was a member of the Adult Blood and Marrow Transplant Program at the University of Minnesota, where she was also a professor of medicine. Additionally, she served as the Inpatient BMT medical director and the director of the institutional site-specific teams. In December of 2014, she joined the National Marrow Donor Program, Be the Match, where she served as the medical director of the Health Services Research until July of 2019. With all of that said, it's my pleasure to welcome Drs. Khera and Burns. Thank you for joining us today.
Thank you so much, Leigh, for the introduction and for the opportunity to have us be here today to talk to your audience about transplantation for older patients with myelodysplastic syndromes. I am very glad to be co-presenting with Dr. Burns from CIBMTR, and we are going to present on behalf of CIBMTR, which is our bone marrow transplant registry, and BMTCTN. We have a task force on evidence into practice. And just for those of you who may not know, BMTCTN is an organization with a membership of about 100 transplant centers that helps conduct trials in the space of transplantation and cellular therapy for hematologic disorders. So we have no disclosures. So over the next few minutes, we will be talking to you about myelodysplastic syndromes, a little bit about their epidemiology, the clinical features, and then we will focus most of the talk on role of allogeneic hematopoietic cell transplantation for myelodysplastic syndrome. While we introduce the transplant process, and we will describe the results of some recently done observational studies and clinical trials. And we will try to end by listing some potential challenges for patients and providers to be able to get to transplant for myelodysplastic syndrome. So to start with, what is MDS and how common is it? It is a group of bone marrow stem cell cancers that is defined by low blood counts, marrow dysplasia, which means abnormal looking cells, and chromosome changes. It is characterized by need for transfusions, and there is risk of infections due to low blood counts that are seen with MDS. It is a disorder of older people. Most patients that are diagnosed with MDS are in their 70s. It is uncommon before 50 years of age. Overall, when we look at the prevalence of the disease, it is a relatively uncommon disease. If you just put it in perspective, it's about 10,000 patients are diagnosed with MDS each year in the United States as compared to about 325,000 with breast cancer. And that does not by any means indicate the severity of the disease or the efforts that we need to make in order to eradicate the disease. So how do we classify MDS, or what is the first thing that we would look at when we are seeing an MDS patient in order to come up with a treatment plan for them? The first thing is risk stratification. And when I say risk, the risk means the risk of MDS evolving into an acute leukemia or a full-blown blood cancer. And this risk schema was developed by Dr. Greenberg and colleagues, and it is based on 3 or 4 different factors. The first factor is which blood counts are low and how low. So is it just the red blood cells? Is it the white blood cells? Is it a combination of that and platelets? So we look at the criteria for the cell counts. The second thing we look at for risk stratification is the number of blasts, which are these abnormal looking, both structurally and functionally abnormal cells in the bone marrow biopsy. And the third thing that we use for characterizing risk is the type of chromosome changes. And again, these chromosome changes can range from what we call good risk to intermediate risk to high risk changes in determining the overall prognosis. This traditional risk scoring system is used at the time of starting a newly diagnosed MDS patient with their treatment. And as you see on the right side, the graphs show that this has been able to very nicely stratify or help us prognosticate for these patients. The ones with very low, or the patients that are in the very low or low risk categories, this green or gray bar, do much better in terms of not just survival, but also in terms of their freedom from evolving into acute myeloid leukemia. One limitation that we have with this traditional risk scoring system is that we have a lot of new data coming up for molecular markers or genetic mutations. And right now, this is not a part of the prognostication, even though our studies are showing that these mutations by themselves will have an effect on the prognosis, and some of them even on the treatment choices. So that is something that hopefully we will see in near future where they will be incorporated in the risk stratification system. And the second thing is what is very important is the response to treatment. So somebody may start off on in a low risk category, but over time, depending on what treatment they get, if they start progressing, their disease trajectory may change to a little bit more aggressive, and that has to be taken into consideration when deciding treatment. So how do we treat MDS? Treatment options can range from conservative supportive care, which would include transfusions, growth factors to help improve blood counts. They could include disease-modifying treatments or so-called gentle chemotherapies that we use to treat this. They may change how the disease progresses. They may provide us a long time of or long time interval in which the disease may hold steady, but they don't cure it. The only potential cure that we have for MDS at this time is a hematopoietic cell transplant, also called as a blood or marrow transplant or stem cell transplant, that uses someone else's stem cells. And that is called an allogeneic transplant as opposed to autologous transplant, which is where you get your own stem cells. So how do we decide what treatment approach is best for our patients? Again, there's 4 main factors that go into determining what treatment we be recommending for someone. The first and foremost is patient age and fitness, and age by itself is a number, but more important is the other medical problems and overall fitness or physical functioning status of our patient in determining how aggressive we can be in recommending treatments for them. The second thing, as I mentioned, is the risk category. Mostly the low-risk patients are treated with conservative measures or supportive care, as opposed to the intermediate or high risk where we have to recommend something more. Patients' goals and wishes obviously are very important. What do they want in terms of quantity versus quality of life? That goes into the decision making as well. And finally, risks and benefits of the treatment options, which for transplant we will be showing you in very soon. So what is an allogeneic hematopoietic cell transplant, or what we call BMT or stem cell transplant? So this is where the patient is able to get cells from their donor, and these stem cells could be harvested from the bone marrow or from the peripheral blood of their donor. And the third option that is the cord blood, which can be used also for these patients, especially if they do not have optimal donor options. So what a patient goes through for a transplant is they receive the healthy stem cells, or we call it a graft, from someone else. And this donor can be a family member. So it could be a matched sibling. It could be an unrelated donor, which we would identify from our international registry, or it could be the cord blood, as I just mentioned. The rationale for doing transplants is that these new stem cells will grow and replace the damaged stem cells of the patient, and that the new immune system can then help eradicate or destroy any disease cells in the patient's body, thus giving us the chance for cure. We call this as graft versus tumor effect. So transplant is not a trivial procedure. There's a lot of decision-making or a lot of thought process that would go into deciding whether a transplant is the right option for a patient or not. There are benefits such as I mentioned, that is the only potential cure that we have at this time, especially for our patients with high-risk MDS or those with no response to non-transplant treatments. If they continue to require transfusions despite the non-transplant treatments, that sometimes can be an indicator that a transplant may be needed. There are immense risks, and they would include risk of early complications after transplant, which could be infections, organ damage, and it could be graft versus host disease. So graft versus host disease, and I think Dr. Burns will be mentioning that in her part maybe, is basically we give you stem cells from your donor hoping that they would fight your MDS, but those stem cells then, there are cells in the graft that can then start targeting or attacking the patient's body. They could attack the GI tract, they could attack skin or liver, and in the long term, basically any organ of the body. And that is one of the major complications that we have to worry about for transplant. In addition, there are later complications such as delayed infections, again, delayed organ damage, or chronic GVHD, which is a long-lasting complication associated with poor quality of life for our transplant patients. As I mentioned, it's a potential cure. It's not a 100% guarantee. Even after transplant, there can be relapses, although the rate of relapse is much lower, as we will show you in the studies in the subsequent slides. That is after transplant rather than in those that do not get transplant. And then there is risk for secondary cancers at 5 or 10 years down the line. And the other thing is that it is a very expensive, very intense procedure. There are immense psychosocial implications of the transplant, in like need for a caregiver, sometimes need to relocate near a transplant center, and all of that again has to be considered in deciding whether a transplant is an option or not. So Despite all of this, there was very scarce data about the effectiveness of transplant, especially in our older patients, the 65 and above Medicare beneficiaries. So in 2010, CMS, which is the Center for Medicare and Medicaid Services, came up with this program called Coverage with Evidence Development, whereby they said that they will cover a transplant as long as the patient was enrolled on an observational study to systematically look at the effectiveness of transplant. So this was then, the study was then developed by our Bone Marrow Transplant Registry, or CIBMTR, the full form of which is Center for International Blood and Marrow Transplant Research. And so what this study did was compare our older patients, those above 65 years of age, with younger patients that was 55 to 64 years of age. And the results of this observational study were published just a couple of years back. And basically, as the curve on the right shows, that the survival outcomes were quite comparable between younger and older patients. And so this did lay some background for the role of transplant. However, as a lot of you may realize, that the gold standard in our research is a clinical trial. And so that's where the field moved forward. And today we'll be talking to you about two nicely done studies or clinical trial studies that have been reported very recently and have also strengthened the role of transplant for myelodysplastic syndromes. The first study is a US study. It's a biologic assignment trial of reduced intensity hematopoietic cell transplantation based on donor availability. And this was conducted by BMTCTN, which I mentioned is the organization that conducts clinical trials in the US for transplant and cellular therapy. The second study is a Vidasa allo study. This is a German study, and it's a smaller study, but they sort of had a similar population, and the message that they were able to derive from the study was also quite similar, and we will be talking about that soon. So I will just start by going over the BMTCTN 1102 study, which is the US study. This was a biologic assignment trial. What that means is that instead of randomizing people, where normally we would, have a computer decide whether a patient goes on the study arm or the control arm, this was dependent on the availability of a matched related or unrelated donor. So after enrollment, these patients, or the study patients, had a search done to look for matched related or unrelated donor. And if they were able to get a donor, then they proceeded on to a transplant using lower intensity conditioning regimen within 6 months of enrollment. And in this study, there were 260 patients that received transplant on the donor arm. If they did not have an optimal donor, then they were treated with what I mentioned, the gentle chemotherapy called hypomethylating agents, or best supportive care, as was decided by their physician. And there were about 124 patients in this arm. The main inclusion criteria for the study was higher risk MDS, 50 to 75 years of age. Any prior therapy was allowed, but they should not have had a prior unrelated donor search done. And the patients had to be eligible for lower intensity hematopoietic cell transplant from a matched related or unrelated donor, meaning that they had to medically meet the criteria for going through this intense procedure. The primary endpoint that the study looked at was how many patients lived for 3 years. The secondary endpoints were how many lived for 3 years without leukemia. We call it leukemia-free survival. They also looked at quality of life and cost effectiveness. That actually has not been reported. The cost effectiveness piece, we are still awaiting that data. So what this study found was that patients who were on the donor arm and were able to go to transplant did better than those who did not. So the survival on the donor arm was about 48% as opposed to about 27% for those who did not get transplant. And similarly, there was an improvement in the leukemia-free survival as well. More people lived for 3 years without leukemia if they were on the donor arm versus no donor arm. Surprisingly, they also had assessed quality of life. And what they showed was that the quality of life measured through many different tools to assess quality of life was quite equivalent at multiple time points before and after transplant, as opposed to those patients who did not get transplant. So that was considered to be very comparable. So with that, I will turn it to Dr. Burns to go over the German study and some more details about the transplant procedure. Thank you.
Thank you, Dr. Khera. As Dr. Khera noted, I'll be talking about the second prospective trial, which means enrolling patients and then watching how they do on therapy. And this was a smaller study that was conducted by several transplant centers in Germany and published by Dr. Kroger last year in the Journal of Clinical Oncology. And so this study had a little bit different approach than the BMTCTN 1102 study. It was similar in that the patients that were eligible for this study had higher risk MDS, 55 to 70 years of age, no prior therapy, or they could have had one cycle of that more gentle type of chemotherapy. We also call it a hypomethylating agent, a huge word. It's known as 5-azacitidine, and the brand name is Vidasa. And as with the BMTCTN study, the patients had to be eligible for this lower intensity transplant from a match-related or unrelated donor. And these lower intensity transplants, what they do is they use smaller doses of chemotherapy and or radiation to make it safer for an older patient to undergo a transplant. It has been shown over the past couple of decades that these lower intensity transplants have similar outcomes as the higher doses of therapy. So that's been a huge advance in our field that has come about through clinical research. So patients meeting these criteria were enrolled, and they could receive up to 4 cycles of 5-azacitidine while the search was going on. Now, 4 cycles turns out to be about 4 months. And as you saw in the BMTCTN trial, the patients needed to have a donor within 90 days. And so here was a little bit longer. And if they had a donor, they were assigned to the donor arm. And as they were waiting to get everything done to head to transplant, if needed, they could have 2 more cycles of 5-azacitidine for a total of 6. And there were 81 patients on this arm, so a much smaller study than the United States study. If the patient did not have a donor, then they could continue on receiving this less intense chemotherapy, 5-azacitidine, and there were 27 patients enrolled on this arm. And as with the BMTCTN study, the primary endpoint was a patient that how many lived for 3 years after transplant. And the secondary endpoint was lived for 3 years without their leukemia coming back. Next slide. Next. So what were the results of this study? Dr. Khera just showed you that there was an advantage for transplantation versus azacitidine or best supportive care in the BMTCTN study. And in the German study, on the left panel are the patients who lived for 3 years. And it shows starting at 100% patients being alive, decreasing over 4 years. And the transplant group is in that red curve, and the 5-azacitidine is in blue. And you might think that those curves look pretty similar, a little different, they cross, and you would be right, that when the statisticians looked at this and did all their special analyses, that it wasn't statistically significant, except for there was an advantage of transplant in those patients who were 65 years of age and older, and if their disease had responded to those 4 cycles of 5-azacitidine, 4 to 6, at time of transplant. But what about patients who lived for 3 years without their leukemia coming back? And here there was a very clear difference. I think you can see a real separation of the transplant curve in red and the 5-azacitidine curve in blue. And so these were really similar results to the BMTCTN study, showing an advantage for older patients undergoing transplantation if they had a suitable donor. Next slide. So the take-home message from these clinical trials is that patients that have higher risk MDS, older patients, if you have a suitable match-related or unrelated transplant, that you can safely undergo transplantation. There is some risk, but you can safely undergo transplantation, and importantly, as shown in the BMTCTN study, have a similar quality of life. And that is incredibly important and was a strong message that we are able to provide to patients as well as their loved ones and doctors caring for them. And that this reduced intensity type of conditioning regimen, less intense transplantation, we really urge that it be considered upfront when thinking about how to effectively manage this disease in older patients. And to do so, we really want our community physicians and treating physicians to refer patients for consultation at time of diagnosis, so the transplant team and the treating physician can work closely together. Next slide. So this is a suggested management plan or algorithm. Remember when Dr. Khera talked about that when you're diagnosed with MDS, that we can look at blood counts and chromosomes, those type of things, blast counts, and assign a risk score. And those patients with their disease may be a lower risk or a higher risk. But as she mentioned, research has shown that we're now starting to understand that there are patients that have low risk disease, but that genetic mutations and transfusion dependence can take those patients who are actually in low risk and move them more into a higher risk category. Those are kind of some bad things that we see, and we're going to learn more in the coming years. So right now, what we recommend, if that a patient has some of those higher risk features, that those patients follow the high risk algorithm, which is the bottom panel, and that would indicate a transplant consultation for higher risk disease at time of diagnosis, and to move to transplantation if a suitable donor is available and the patient is healthy and medically fit to undergo transplant. Next slide. So what does a transplant mean for you as a patient? You know, it's just, what is it? Well, let's just talk through the process a little bit, and I think that'll help you understand what it entails. So typically a patient may be diagnosed when they go in for a blood count for having their gallbladder removed or something very simple, maybe even just an annual physical examination in an older patient. And that would lead then, if the concern about blood counts, to a specialty doctor, such as a hematologist or oncologist. And they would help make that diagnosis and refer you to a transplant team to see if transplant is the best option. And the transplant team works very closely with the doctor in developing a care plan, because as you can see, that the German studies show that 5-azacitidine can help put the disease in remission, and remission may be a good thing for undergoing transplant because you're less likely to have your disease come back. We also need some time to search for a donor. As you saw, was 3 to 4 months for a donor search. And that's fairly lengthy of time to then help try to keep the disease under control and identify the best possible donor, and then coordinate a date for transplant with the patient and the donor. And prior to transplantation, you would undergo a comprehensive evaluation. Really, particularly in older patients, it's important to have what we call a geriatric evaluation. We know that older patients have other health issues, particularly physical and cognitive, how you think, how your brain functions, organ evaluation, make sure you don't have infections. And so that would be done at the transplant center to make sure your disease is under control and the timing is right for a transplant. Next slide. I want to tell you about a new program at Be the Match that was started last year, and it's called HLA Today. And HLA stands for Human Leukocyte Antigen. That's a big mouth of words, but what it means is that these are proteins on the surface of cells, And this is how we know if we can find a donor who matches you, has the same HLA type as you do. And what the National Marrow Donor Program, Be the Match, the goal of this program was really to shorten the time of having this typing done and getting the search started, because time can be of an essence. And so the Be the Match provides community physicians free kits where the inside of the cheek, the inside of your mouth is swabbed. And that can be sent for HLA typing. This is free. You can also request to type family members to see if there's a family member who could serve as a donor. The family member report would be sent to your physician, and Be the Match would send an unrelated donor report, looking to see if there are unrelated donors available. And that can really shorten the time then when you go for your transplant consultation to really have that typing already done. Saves a lot of time. Next slide. So we talked about getting ready, getting some typing done, being seen in consultation, having this evaluation, make sure you're ready for transplant. Okay, now what? When you're ready for the transplant, you would be admitted to the transplant unit at the hospital. You would undergo this less intense therapy called a conditioning or preparative regimen, and that takes several days. And then on day 0, that's when the new stem cells from your donor would be infused. And it's just like similar to getting a blood transfusion. A catheter has been inserted into a large vein before your transplant starts. That's used for giving chemotherapy and all your other medications. And that's where your new stem cells are infused. And then it's a waiting game, so that we know that different types of grafts and sources recover at a little bit different time. But the main thing is, while we're waiting, is to keep you as healthy and comfortable as possible. That means keeping you free of infections, watching your organ function, nutrition, physical therapy. So you would have a full team with lots of resources that would be assisting you here. And I failed to mention that there's so much education that is done for both you and your caregiver and family prior to transplantation, again at time of admission, and then in time of discharge. So how do you get discharged from the hospital? That's one of the #1 questions. Okay, I'm here, I had my transplant, when I can get out of here. And a couple of things, you have to be able to be up and about and take a shower and get your clothes on and be able to be as an outpatient, do the basic things of life. You need to be able to eat. You need to be able not having any major infections so that you can live as an outpatient. And so instead of being an inpatient, the doctor and the team come to see you, you're an outpatient and you're coming in to see the doctors and care team in the clinic. And typically that needs to be done for at least 100 days after transplant. So you might be in the hospital for 3 or 4 or 5 or even 6 weeks. And then any additional time up to 100 days, you would need to be as an outpatient with a caregiver 24 hours a day. Finally, around 100 days, if things are going well and that you haven't developed any severe, this graft versus host disease that Dr. Khera spoke about, and if you have, it can help keep disease away, keep it from relapsing, but it would need to be managed. And then you would be transferred back to your community physician, and your community physician and transplant doctor would work as a team. Next slide. So what determines the success of transplants? Well, you've heard us tell you that if we can get that disease in remission at time of transplant, that's better. And if it hasn't transformed into that aggressive acute leukemia, that's really great. So the timing has to be right. And the things that we talked about, you're healthy, you're pretty strong, no infections, but importantly, and we want to stress this, that this is a difficult process. You will get through it. You will need the support of family and friends because it is a long haul. And the more that you can plan and have a great support system, the better you'll feel, and you'll feel supported. Next slide. So we mentioned earlier on that as part of this BMTCTN task force, Dr. Khera and our other colleagues across the nation have been trying to identify the challenges and barriers that the patient considers when they're thinking about going to transplant, as well as a healthcare provider. And so our patients told us when we asked them, and we have patients on our task force, and just incredible to hear from them what they see as a patient and what we see, as a healthcare provider. So what are patients concerned about? Risk of transplantation is really kind of number one, and that makes a whole lot of sense. You're really balancing the risk of having a complication, a very severe complication, versus a chance of cure. But there's a lot of social issues, right? I grew up on a big farm in the middle of Missouri, and there's no transplant center 4 hours away. If you are out in a rural area and you've got a long distance to go, that displaces you and your family and your caregivers and transportation and where you're going to stay. The transplant center is really supportive and can help with these. But this is, again, a reason to get to a transplant center early to have time to plan. Putting together caregivers to be with you 24 hours a day, 7 days a week. It takes a lot of planning. What about money? Finances are tough. Insurance may cover. If it's Medicare, Medicaid, we talked about that observational study, that if it's under that program, will be covered. Worry about optimal donors. This is of importance for patients who are ethnic and minority groups, for which there aren't as many potential donors in the registry. But we say in this day and age, given so many types of graft sources, whether it's matched or unmatched, unrelated, related, or cord blood, that most everyone can identify a donor and proceed with a transplant. Well, what about healthcare providers? What do they think there might be barriers? Well, one thing is that as we talk amongst ourselves, that transplanters do this type of procedure day in and day out. But if you're a community hematologist and oncologist, myelodysplastic syndrome is pretty uncommon, not nearly as common as breast cancer or lung cancer. And so it can be difficult for a community hematologist and oncologist to really stay up to date. And transplant has had so many advances since when they may have trained. So that's something that we need to work on as transplant physicians to really help provide education for our colleagues. They worry they might lose the patient. What does that mean? Well, if a patient goes to a transplant center, maybe does this transplant center, they're going to return them. And so that is something that transplant center has been working on really, really hard to make sure that it's a coordinated care system to transplant and back, and to coordinate that care for all the providers. And then the provider also was concerned about whether or not their patient will have coverage. And what we tell our community physicians is that the transplant center has a really great program set up for looking at finances for patients, and that we can handle much of that at the transplant center. So get them referred and we'll sort it out and help sort it out. Next slide. So what can you do to prepare for the transplant experience, improve your chances? Well, ask questions. Ask, and if they don't speak in a language you can understand, ask again. Take someone with you, write it down. Select a transplant center. You might think about location, but when you visit, see if it feels good. Are those team attentive to you? Do you feel that this would be a program where you would feel well cared for a long period of time? And also, many transplant centers are developing what we call survivorship programs to help care for survivors of transplant, to help prevent any late complications. So see if that transplant center has a survivorship program. Stay healthy, don't drink, don't smoke. Start thinking about your caregiver plan and start looking at finances, how you will manage your finances, both out-of-pocket cost, travel cost, transportation, out-of-work cost. Next slide. So what about if you're a caregiver? This is a full-time job, and it's really important to think about the areas that you will be able to support your patient. It's just not medical, but also helping them sort out the finances and listening and supporting them. But importantly, also to take care of yourself, because it is a major undertaking. And there are many resources as listed here. AA MDS has a variety of resources for caregivers, as does Be the Match, other societies and foundations. Transplant centers have a lot of support groups and social workers who provide resources. Next slide. And how can providers help patients and caregivers? Well, I think we have a responsibility to provide education before, during, and after a transplantation to make sure you are able to make the best decision for yourself, work with community physicians for early referral, work with insurers about coverage of transplantations, develop strategies while patients undergoing transplantation to help reduce risk, partner post-transplant care, social support for particularly for older patients, and importantly, both patients and providers. Patients participating in research and providers participating in research has really advanced the field. And so I encourage you, if you have opportunities to participate in clinical research trials, to discuss those with your provider and see if that would be something that you want to participate in. Next slide. So what are the take-home points? It's the who, when, and how. So who should think about an allogeneic transplant? Patients with high-risk MDS who are otherwise medically fit. And again, a geriatric assessment can be really helpful in that regard to determine if the patient is physically able to undergo transplantation. And sometimes if a full assessment is done, there are things that can be done to improve the eligibility, such as a rehab program if needed, to get the strength built back up. Referral early in the disease course leads to the best outcomes. We'd like to have the disease under the best possible control and no infections and otherwise fit. And I think I have showed you there's lots of steps that go into this pre and post-transplant care, but don't let it overwhelm you. There is a huge support system at the Transplant Center and other societies and foundations to help support families, their caregivers, and loved ones. Next slide. So with that, I want to thank you for joining us today. I want to thank all those patients who participate in the clinical studies that we showed you because it's made a huge difference. To thank their families and the caregivers who've supported their patients. Our thanks to the AAMDS for inviting us to be here today, and our partner societies of the CIBMTR, BMTCTN, Be the Match, and all the members of our task force who have been helping us get the message out regarding the outcomes of transplantation for older patients so the best decision can be made for management and care. That concludes our webinar and our presentation by Dr. Khera and myself. Now we'll turn it back and Lee will help us with a question and answer session. So I hope you've got your questions already so that we can have a great discussion.
Thank you so much for the wonderful presentation. And we have some great questions. Our first question is, how old is considered to be too old for a transplant?
Well, I can take that one. So I am 67, so I am an older individual. And when I started transplantation in 1984, the upper age limit was really around 45. And now many centers don't have upper age limits. As Dr. Khera said, it's age alone is not the only factor. It really is whether the patient is medically fit. But most centers don't go above around 75. And as you saw, that's where the studies that we demonstrated had an upper age limit of around that age. And so it's really important for the community physician to have close contact with the transplant centers in their area because each institution develops their own internal standards about age, but medical fitness and overall health is a very critical aspect in conjunction with age in determining medical fitness for a transplant.
Thank you. Our next question is, if I was asked to consider a transplant at age 75, and this was 2 years ago, the patient has a low-risk diagnosis, felt fine, and they're still not needing any treatment. Is there any point in time they should reconsider having a transplant if they have a suitable donor?
So I can go with this one.
Okay.
Our studies have shown that for low-risk MDS patients, the transplant sooner rather than later transplant can actually be more risky than the benefits that it provides. And that is why we don't even offer that to our low-risk patients, especially because a lot of them we could just be doing monitoring or, often on supportive measures. And so I would say unless your disease trajectory changed to more aggressive, where you started needing transfusions or your counts started to decline, at that point, assessing where exactly you stand would be important to decide what treatment option would be the best for you. But going back to the first question, a lot of programs do have 75 as the age cutoff, including our program, I have to say. And that's partly because we feel that the risks of doing it for older patients or the longevity that we would hope, we may not be able to get that with transplant beyond that age. So
Thank you. Our next question, this patient has a brother who's 71 and a sister who is 78. Both are perfect matches for the patient. Is their age a problem for being my donor? I'm 74 and they were treated with ATG cyclosporine 10 years ago. Is there an age cap for being a donor?
I can take that one as well. That there are several things to take in consideration when deciding on which is the quote best donor to use for a patient. We always look at family members, an HLA matched sibling, as perhaps providing the best. Those older donors, as we age, our bone marrows kind of change and our cells change inside our bone marrow. And as we're learning more about donors who are older, we have some concerns about that. And particularly when I'm hearing that somebody received ATG or cyclosporin, I was wondering if that patient had some kind of bone marrow failure syndrome and received some treatment. So typically in that age range, more and more transplant physicians then are looking for a younger donor source, including such as a matched unrelated donor. Dr. Khera, would you like to comment on that too?
no, I totally agree. I mean, there's no age cutoff as such for a donor, but we do believe that older donors may have sort of inherent problems with their stem cells, which is why we prefer not to use those. And as Dr. Burns mentioned, we are starting to see some more what we call familial MDS syndromes emerge, where we know that certain genetic mutations may actually be not just the patient, but some of the family members. It's a very, very early kind of research, and we will know more, but that always makes us a little concerned about using older donors for our patients.
Our next question, can donor stem cells be stored for future use?
That's a really good question as well. And it's been a particular interest during the recent COVID pandemic. And when we say donor cells being stored for future use, typically we prefer to infuse the stem cells before they have been what we call cryopreserved or frozen and then stored. Because with the storage procedure, we know that some of the cells may die off or not be as healthy after they're thawed. So we prefer to infuse fresh, but cryopreservation or storage can be done. It's typically a temporary issue. We don't talk about long-term storage for years and years, particularly in an allogeneic setting. But with the COVID pandemic, the National Marrow Donor Program, Be the Match, did facilitate more cryopreservation or storage of donor cells just because of pandemic issues and donors and the timing. And those transplants can work very, very well. It can grow and engraft and lead to wonderful outcomes. But it's not the typical practice.
Thank you. Our next question, does a transplant eliminate genetic mutations?
That's a great question. That is the hope that they would, and that's where we hope that the graft versus tumor effect can help us develop a marrow that is, or develop stem cells that are free from the mutations. That being said, as this field is evolving, we are learning more and more. Traditionally, we were not even following some of these mutations after the patients got transplanted, but now we are. And specifically, there's a very bad mutation called P53 mutation that has been looked at because it can indicate some aggressive disease. And there are studies showing that there may be some role with the transplant of being able to clear this mutation and therefore cure the patient of their underlying disease that may have resulted due to that mutation. Dr. Burns, any thoughts from your side?
No, I think you're exactly right, Andy. Dr. Khera, the hope is that those new cells, infused cells, take over, eliminate any and all disease, and that the disease never comes back. We are starting to follow those types of mutations as a marker of the disease, and both before transplant and afterwards to get a better understanding of the amount of disease that still may be present in a patient's body, and if it occurs afterwards, maybe a signal of relapse of disease where we can intervene and help prevent it from becoming worse. So lots of research going on in that area. It's a great question.
Thank you. This question is in regards to the donor. It's actually two questions. How intense is the donor process? What is the procedure for the donor? And in terms of for the donor, how is it regarding pain, time, and potential infection?
That's a really, all these questions are great. We say that's a great question, but they're all great. They're asking a variety of different things that really are important. So what is the process for the donor? So the donor undergoes a HLA typing, and we showed you that that's typically just a swab from the inner cheek. It can be done from a blood sample. And if they are an HLA match, they undergo a physical examination and clinical examination to make sure they're healthy to donate, right? That they're healthy, that they don't have any disease that wasn't diagnosed before, but typically donors are relatively young. In unrelated donor setting, the most common age group that donate are 25 to 35 years of age. The cells can be taken either from the bloodstream, so from the veins, in a process called pheresis. It's kind of like donating blood. And in order to get a lot of those stem cells out into the bloodstream, you usually take a medication for several days, typically underneath the skin, to help those stem cells come out into the bloodstream, hooked up to this donor machine. And that may be 1 day or 2 days to get enough stem cells. And then the growth factors that we use to get those stem cells coming out in the bloodstream, that can cause some bone pain, sometimes some nausea, sometimes some fevers, but those effects are usually easily controlled. A bone marrow source of stem cells means typically that the patient who's the donor, would undergo general anesthesia in an operating room. And then the marrow would be removed from, where a baby has those little dimples in their back, in their lower buttock area. That is the pelvic bone, and there is a huge source then of stem cells, and needles is used to extract that. Most patients will have, some tenderness and some soreness there for 2 or 3 days and then feel better, although some patients will have some lingering discomfort or symptoms. And how a transplant physician chooses is that we know that there are kind of pros and cons to peripheral blood stem cells or bone marrow cells, and your physician would help make the best choice for the particular recipient. Dr. Khera, would you like to add to that?
No, I think you covered it pretty well. And the good thing is that as a field, we are also very concerned about donors, and there are studies looking at outcomes in donors, and basically they have shown that there's no long-term safety concerns or anything for the donor. Yes, there are some temporary discomforts, especially with the bone marrow harvests, but mostly our donors do okay.
That's a really good point. The National Marrow Donor Program, Be the Match, because of the very large unrelated donor registry, has done a lot of studies looking at that. And when we first started using growth factors to cause those stem cells to come out in the bloodstream for donors, there was a worry that that might cause some problems. Would that make cancer occur, or leukemia? And that's never been shown. So overall, the donation process is very safe, but it's not without zero risk.
Our next question is, what are the best health indicators for likely transplant success?
Some of the general, go ahead, Dr. Khera.
Oh, that's okay. Oh, okay.
I'll talk about some of just the general ones, and then perhaps Dr. Khera could mention some of the things we're doing in geriatric assessment. So just the general ones that we take a look at when a patient's evaluated is first, is the disease under control? Has the patient responded to their azacitidine? Or rarely we're starting an evaluation for a patient and we have some bad news that the disease has progressed to the leukemia. So assessment of where you're at with the disease. But secondly, then taking a look at organ function. And that can be tests that assess how the lungs, the heart, the kidney, the liver, how they're doing. Are they in a good place? But we also look at what we call a comorbidity score. So there's a series of things that we look at in terms of high blood pressure, heart disease, obesity. Have you had previous cancers? Have you had renal problems? So a whole bunch of things that we can take a look at, and that can help us predict whether or not a patient is going to have some complications post-transplant. Dr. Khera, to add to that?
Yeah, so just, that's what, when I talk to my patients, I go over some of these things. And yes, disease status is very, very important. We know that the best outcomes are if the disease is under good control before transplant. Organ function is important. There should not be any uncontrolled infections. And then I think there is some, just general physical conditions. So overall functional status, we know is a good indicator of the success of transplant. And so we try to optimize that as best as we can before. And then finally, good psychosocial support system, having a caregiver, having the financial resources to be able to manage your medications and other necessities during the post-transplant period. We try to assess all of those in order to decide what we need to do to help address these kind of issues for our patients to optimize the chances of success for the transplant.
Next question is, what types of exercise could someone do to strengthen themselves in preparation for a transplant? And are there any other suggestions on what a patient can do to best prepare?
Dr. Khera, would you like to start?
Yeah, I mean, in terms of exercise, we don't really want you to be like lifting heavy weights or any kind of major this thing, but just as long as you are staying active, you're able to walk. In general, I would say most of our patients, we try to make sure that they are able to manage all their daily activities and do a little bit additionally to take care of themselves. If there are a lot of issues with just in terms of frailty, then we do try to refer patients to physical therapy prior to help with sort of the prehabilitation process before transplant. And then in terms of the other issues, I think Dr. Burns had that on the slide, whatever you can do to stay healthy, stay active, optimize your nutrition, try not to get any bad infections, and then create your support plan, caregiver support plan, and all of that. I think those are some of the things that we tell our patients to do to improve their chances of success.
I would just add to that about the geriatric assessment. I think, and this has come about through a lot of research, that there are geriatric oncologists and geriatricians who have expertise in assessing older patients. And many centers are starting to develop these type of programs for a little bit more detailed, nuanced evaluation of older patients with the focus of trying to improve their physical and or mental function prior to transplantation. So that's also something, as you're thinking about transplant centers, ask about those types of evaluations.
And our last question is, what is a successful transplant?
Successful transplant means that you undergo the transplant, you have no major complications, and then you live a long and healthy life, and that your disease never comes back. Many patients will have some complications, maybe some that last for a while, but many of them can be aided and mitigated. So really to get that new stem cells in there and functioning to correct the blood disorder, and the blood disorder not to come back. But then there's other things in terms of quality of life, which was so important. But if you have a transplant and you're cured of disease, but your quality of life is not good for all the complications. And that's why that was such an important part of the BMTCTN study that showed that patients that underwent a transplant versus patients that didn't had similar quality of life. I think that was really exciting to see. Dr. Khera?
No, I completely agree. Being free from the disease for which the transplant was done, being free from some of the transplant complications, and having a healthy quality of life, I think that's what you hope for with the success. I have to say, I've heard it from a lot of my patients that the normal changes. It's not quite the same as they were before transplant, but that being said, we all evolve based on how the circumstances. And so as long as you are able to be happy with the condition that you're in after transplant, I would say that is the indicator for success.
Thank you so much, Dr. Burns and Dr. Khera, for sharing your time and your expertise with all of us today. Very much appreciated. And if you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us anytime within 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you again, Dr. Burns and Dr. Khera, for your time today.
Thank you.
Welcome, our pleasure.